Thanks so much for that introduction, Joe. I appreciate the invitation. And I gotta tell you, it's really dangerous to invite a sleep person to one of these talks, particularly postprandial. You put a lot of people to sleep talking about sleep. And I have, but it's okay. It's actually your circadian rhythm, and I will be actually fine if you fall asleep on me. I've accomplished my job. It's a pleasure to be here. You know, I was thinking about all the presentations today. They have a unifying theorem in some ways. You know, if you think about electricity, magnetism, they've been looking for the unified theorem to put it all together. I'll put it all together: sleep. You sleep, your cognition is better, you age better, and so on. So let's see if we can prove some of that. I'll move my slides. Okay, it's a lot to talk about sleep in 15 minutes, so I just wanted to highlight some really top topics that are of interest. We can get into many issues, and I don't have the time for that, so I'll cover the big ones. I'll do a brief review of some of the various sleep disorders that exist. Talk about population epidemiology of two common things that we've been focusing on, and two common things that are relevant for the general population and for those living with HIV. And then talk about what we knew about HIV and sleep from the last decade and what we know now as we're emerging into the next decade of extending lifespans in those with HIV. So let's start with what we know about sleep disorders. There's 90+ disorders according to our nosology. And you could look at it graphically. There's a little sort of astrological chart on the left. It's actually not astrological, it looks like it, but every single sleep disorder, believe it or not, on that thing is represented in some ways. You could look at it a much more better graphic. There are many different types: insomnia, hypersomnia, narcolepsy, these things that you've heard about commonly in clinical practice or the lay press. Sleep apnea is one of the more common ones, particularly because as we have sort of gained in our obesity epidemic, sleep apnea has become really prevalent and taken stronghold on that. So it's important to emphasize, to understand the relevance of that. We now know over the last 2 decades, sleep apnea is not a trivial disease. Hypertension is highly prevalent and associated with, and sleep apnea is a risk factor for hypertension. So what do we know about population epidemiology of sleep apnea? I think it's important to sort of look at that. Pathophysiologically, we now know that upper airway collapse during sleep, and there's a graphic here where the soft palate and tongue literally collapse back due to decrease in motor tone. And that collapse of the airway leads to recurrent episodes of hypoxemia and arousals from sleep. The brain actually prefers to live and breathe than to sleep. So sleep can be sacrificed. It's interesting. The brain really prefers oxygen. And therefore, the discontinuity of sleep has been associated with a variety of different clinical consequences. Here's the global prevalence. This is from a recent article from The Lancet, I believe. It shows the global prevalence of sleep apnea across the world. The United States, depends how you define it. We have various definitions of what is sleep apnea, but irrespective and what demography you look at, it's extremely common. I would say at least 15% of the general population has it. As we gain weight, as we age, the epidemiology shows that there's a higher prevalence of this disorder. Menopause, very important. As women go through menopause, sleep apnea becomes more common. Not surprising. Very common issue. Why is it relevant? And this little graphic shows you that, look, if you don't breathe, you don't have oxygen. Your sleep is disrupted. And that leads to a cascade of events: increase in sympathetic activity, generation of oxidative stress, and therefore downstream consequences of hypertension, heart failure, atherosclerosis. A whole host of issues have been examined over the last 3 decades in the area of sleep medicine. Let me switch to insomnia. I can guarantee you, many of you have had insomnia in this room, whether it's for grant writing, paper writing, children, spouses, taking care of elder parents. You've had insomnia, and many of you probably have insomnia. What is insomnia? It's not a diagnostic test that we do. It's a clinical diagnosis, difficulty initiating, maintaining, or both with regards to sleep. Grant writing is a really bad prescription for insomnia. Trust me, I know. Global prevalence is really high. 30 to 50% of the population worldwide has either short-term or chronic insomnia. Right? That's pretty big. So half this world almost has difficulty with sleeping. The graphic on the right shows you with regard to how common every night is all the way on the left. And there's an age-related, trend here. And you'll notice post-pandemic 2022, insomnia has become very common in 18 to 24-year-olds. There's a lot going on. The trends used to be the other way around. Insomnia was more common in the older population, but there's something really stirred up. I don't know if it's the pandemic. I don't know if it's the phone. I don't know if it's a smart tablet. But insomnia has really become, every night insomnia has become very common. 20+% of most of us across the age spectrum have insomnia. 1 out of 5. So what do we know about HIV and sleep apnea? And again, I picked only 2 disorders. We could talk about circadian rhythm disorders. We can talk about restless legs. There are so many other sleep disorders. I picked the 2 more common ones. What about sleep apnea? This is one of the older iterations of the multi-center AIDS cohort study that I'm sure many of you are familiar with. This is an old publication that is now almost 10 years old, 2014. Small sample size from the multi-center AIDS cohort study, which only included men. You'll notice that there were 60 men living with HIV and 60 without. What's impressive about this is the column that I've highlighted in red. The column clearly shows no matter how you define sleep apnea, and we use this thing called RDI, Respiratory Disturbance Index, number of times you stop breathing during sleep, 71% of men with HIV had some degree of sleep apnea. 56% had moderate, and if you go to severe, 46%. So the spectrum of disease is extremely common, and I can tell you, you all are missing it in your HIV population, because this is not being diagnosed, as shown in this study. This is a study from 2015 on a VA cohort, and they looked at 3,683 individuals with HIV and some about 3,600 without HIV, and they showed 3.9% of individuals with HIV were diagnosed, whereas 12% were diagnosed without HIV. So there's a huge discrepancy between case identification of the burden. And I can tell you this much, that sleep apnea is more common in HIV than those without HIV. This, I think, at this point we know. I'll show you the data to prove that. But that last slide was to show you that it's underdiagnosed. That's key to remember. It's underdiagnosed. This is a study from China looking at insomnia. And you can see they do a spectrum of age-related issues about insomnia symptoms or poor sleep quality. The black bars, which are HIV, are consistently higher than those without HIV. It's as simple as that. Individuals living with HIV have more insomnia and more sleep apnea. And that list is much longer. If you look at circadian phase differences, I haven't shown you that. If you look at issues with restless leg syndrome, I haven't shown you that. These things are also common. It's just not being diagnosed. You have to look for it. Even in the general population, these disorders are underdiagnosed. And I think in the HIV, they're even more underdiagnosed than otherwise. So let's get into some new data that have been, we've been behind in with the MAX cohort study and the WISE cohort study. So this is data from the MAX. Most of you know that this is a study that started back in 1984. It's 4 decades old at this point. We popped in with sleep around 2018. So on this graphic, we've been around for a very short time compared to the real history of HIV with MAX. We've recently extended to the WISE, but our real impact thus far has been really studying the longitudinal trajectory of sleep in men with and without HIV. Here's a distribution, a heat map of individuals that were recruited for MAX. In the big cohort as a whole, now of those, we recruited a subset. And we did something really crazy, in my opinion. We went and measured sleep in their homes. This has been done. It's technically very difficult. I was part of an effort since 1994 to do this in the home. We have to send people to the home, wire people up with the brainwave activity, et cetera. But we, along with the company in Iceland, came up with this technology. We didn't develop it, but we used their technology to monitor sleep with self-applied EEG. It's never been done before, but we did it. We took some chances. Retrospectively, I'm so glad we took this chance because what we learned with the EEG is so different than had we not done the EEG itself. We actually got a taste of what their brains are doing during sleep. So, a bunch of sleep guides come up with a lot of parameters. We can tell you how much time they spend in bed, total sleep time. We have these ratios, sleep efficiency, how much non-REM sleep you got, how much REM sleep you got, arousals, how many times you wake up. Whole litany of indices to look at objectively what your sleep is. And we have numerous publications. I've shown you 4 of these right now. The one thing that we're noticing is that HIV affects sleep when something else is present. It's a two-hit phenomenon. I'll explain that to you in a second. Here is our cohort, or rather a sub-cohort of MACs. We have men with HIV, that are about 447 that finished it, and men without, about 350 of them. And yeah, there was an age difference. Men with HIV were younger. They had a somewhat different racial distribution, somewhat different smoking, but otherwise, they were pretty similar to those without HIV. Busy slide, but let's talk about this. Here we demonstrate the prevalence of HIV via different definitions. I've highlighted only two of them in red, where you see the prevalence of HIV, prevalence of sleep apnea in HIV is about 58% if you use our definition called the 4% desaturation index. What this says is that for us to count events, each event has to lead to a desaturation during sleep about 4%. It's used by Medicare, so that's why we showed it here too. Interestingly enough, men without HIV was 50%, men with HIV was 59%. We did some multivariable adjustments and showed that men with HIV have a 42% higher odds of having sleep apnea, as defined by Medicare. And then you could look at it different definitions. I highlighted another one, which is called the oxygen desaturation index. There again, we see the same thing. Fundamentally, it's more common and highly prevalent in HIV. Why? We'll have to talk about that at the end if we have time. We looked at severity. You can classify mild, moderate, severe. Again, I highlighted one box. The leftmost box is no apnea. The middle one is 5 to 15 is mild, moderate, and severe. And what we consistently see is that men with HIV have a higher odds of having mild apnea, moderate apnea, that's where they hang out, but also severe apnea compared to men without. Here's an interesting paper that just got published a couple of months ago where we looked at HIV and diffusing capacity of the lung. And what we found is if you have sleep apnea, your oxygen levels drop. If you have impaired diffusion capacity of the lung, your oxygen drops further. But if you have HIV, it makes it even worse. So it's almost a three-way interaction. You have to have sleep apnea, you got to have impaired diffusion capacity of the lung, which is common in HIV, and then HIV itself. So there's a lot going on. It's not just HIV does this. I don't think we can say that. I think what we showed here in these graphs represent various metrics of hypoxemia. And the key trend that I want you to notice is on the right, it goes up. And towards the right is severe sleep apnea. And the black bars are those with impaired diffusion capacity. Now, if you were to superimpose HIV, those bars are even higher. So it's a three-way interaction. It's a multiple hit theory that we're proposing that HIV by itself may not do anything, quote unquote, seems to increase prevalence of sleep apnea, insomnia, et cetera. But when you add on other things, you really see manifestations of more hypoxemia in HIV. This is a more recent work that has not been published. It's under review. What did we find? Again, busy table. But every box that I've highlighted shows you parameters of how they sleep. For example, sleep efficiency, going from left to the right, shows you how sleep apnea affects it, and then HIV status, top and bottom. What you see consistently is that HIV, individuals living with HIV, particularly if they have sleep apnea, have worse indices, poor sleep efficiency, increase in stage 1 sleep, the lighter stage of sleep, decrease in slow wave sleep, the restorative stage of sleep, decrease in REM sleep compared to the comparators of those without HIV. And you can see this graphically. You know, on the right side, the two arrows that I'm pointing to are total sleep time. Men with HIV and severe sleep apnea sleep less. Men with HIV with sleep apnea, severe sleep apnea, have more wake after sleep onset. Insomnia equivalence, but objectively defined, not subjectively. When you look at these different parameters of sleep architecture, look at the curve that's going all the way up in the right and the left upper panel. What you see is sleep apnea, but men with HIV do worse. More light quality sleep. They flip-flop also less. All of us transition between non-REM and REM sleep. In fact, most of us do this multiple times through the night. What's fascinating is, and this is shown in this thing, these are adjusted models showing men with HIV and one with the HIV status positive and men without. What you see is that they don't make these natural transitions to going into REM sleep, and they don't make transition coming out of REM sleep. Their cycling of non-REM and REM seems to be impaired. I have no idea why, and it seems to get worse if you have sleep apnea. It's sort of like this three-way phenomenon going on. Here's that same thing showing graphically, and the two bottom graphs show non-REM to REM transitions, which are normal, are less if you're HIV positive and have sleep apnea, and then you don't transition as much. So I just wanted to give you a taste of what we're learning from Max and other studies. Sleep disorders are extremely common. Sleep apnea, insomnia. We also know, again, I mentioned restless leg syndrome. These are objectively defined. We haven't resorted to subjective measures which have their biases. And there is a significant association between presence of sleep apnea, HIV, and impaired sleep quality. It seems to make things worse, the presence of HIV, that is. Our diseases like sleep, insomnia, okay, fine. Sleep apnea and insomnia, fine. But that second hit, or that presence of HIV, really exacerbates the things we see. We see a lot of impairment in sleep efficiency, sleep stage instability, and shift towards lighter stages of sleep. So someone's going to ask me, so what? Because I know I heard that one before. And that's the question. So what? I think we need to now progress and understand whether the impairment of sleep is a causal effect downstream to hypertension, cardiovascular disease, because those things we know from our own field, that if you have sleep apnea, you have a higher incidence of cardiovascular disease. Question is, does this parallel that? Is there two-way phenomena, two-way interaction perhaps, between sleep apnea, for example, and HIV, or insomnia and HIV, or poor sleep quality and HIV, and downstream events? I want to quickly thank, of course, the large number of individuals, the two cohort studies that have been used for this thing, and a variety of funding agencies. Thank you so much.